The Ethics in Psychology podcast is created by my dad, Dr. John Gavazzi, a psychologist. The podcast deals with issues related to psychology, ethics, philosophy, and morality. He is going to interview people so that listeners can become better psychologists. Please enjoy this podcast.
Always do the right thing.
That's it?
That's it.
I got it. I'm gone.
Welcome to the Ethics and Psychology podcast. I am your host, John Gavazzi, practicing psychologist, and I'm podcasting from central Pennsylvania. This is episode 4. Episode 4 is Ethical Decision Making, Part 1. This week is a variation on the theme of the typical podcast, or what I've presented as would-be podcasts. Instead of a conversation in ethics, you will be treated to a monologue. And you're probably sitting there saying, what? Yes, it will be a monologue, and hopefully you'll enjoy it. The way that I present ethical decision making does not lend itself to a conversation. And here are a couple of reasons why. Number one, we're going to need a common background to later analyze vignettes. As part of ethical decision making, I typically use vignettes from real-life clinical situations. Therefore, before delving into vignettes, we will need to review or learn some basic concepts about ethical decision-making. Number two, I have done more than a dozen presentations on ethical decision-making, and I've been to a whole lot of other people presenting on ethical decision-making. So different presenters have different ideas about what makes up ethical decision making. Not that my presentations are better or that much different. I would like folks to have the same reference points or use the same language when working on ethical decision making. One brief example is I don't like it when people use the term quote unquote unethical. Why? Because when someone says, hey, that's unethical, it's a surefire way to shut down any conversation. So, as you will learn later, there's a different way of discussing quote-unquote unethical behavior that we will address in the acculturation model. But what I'd like you to do is be able to move away from that dichotomous thinking and just to bracket that term unethical for the time being. Number 3, this podcast will also be available on YouTube, because I'm going to use a number of slides. If you really want to follow along, you may want to watch this on YouTube or review the slides from my SlideShare account before you listen to this podcast. I will place a link to my SlideShare account and to these slides on the Ethics and Psychology page so that you can see them ahead of time. So this will make a little bit more sense. If you dare to listen to this podcast just by listening and no review, feel free. My hope is that you can still follow along. My last introductory thought, because of the immense amount of material, I have to break down the beginning of ethical decision making into 2 separate 1-hour parts, or approximately 1-hour parts. After these lessons, then we can begin to analyze vignettes, which is really where the fun is. Most of the presentations that I do, we discuss ethical decision making first, give everybody, like I said, that common language, those common points of reference, and then we begin to analyze the vignettes. So the next slide is going to be our learning objectives. And I believe the phraseology is, at the end of this podcast lesson YouTube video, the listener or learner will be able to, number 1, describe the difference between ethical and clinical decision making. Number 2, outline the acculturation model. And number 3, list the 5 foundational principles necessary for ethical decision making. There will be much more to learn, but those are the best learning objectives I could come up with given the amount of information that I have to share. Again, this podcast, video, or lesson is for those who are in a graduate program or are currently working in the mental health field. If you do not fall into either of these 2 categories, you might become lost pretty quickly. So the first major point that I would like to make is that ethical decision making is a complex process, or I should have there can be a complex process. Ethical decision making has many factors and variables that are involved. Ethical dilemmas in psychotherapy are fluid. This means that definitive answers to dilemmas can be difficult. Many times we need to evaluate dilemmas on a case-by-case basis. Now, having said that, there are behaviors that are clearly wrong in the practice of psychotherapy. One example is psychologists don't have sex with patients. That is clearly a boundary violation. That is something psychologists are not permitted to do. So that is a very simple, right-wrong example. The second example is psychologists must not disclose confidential information unless in very specific circumstances, such like an emergency or when it's between two providers. Psychologists do not reveal confidential information just to talk about it or just to gossip or have something to say to another psychologist. That really what the person brings into the therapy session is meant to stay in the therapy session, like I said, unless under very specific circumstances. Additionally, because we are all human, we all have our own biases and our own limitations. We have cognitive biases and emotional reactions that will likely skew the way we conceive of what is happening in the therapeutic situation. So this is what makes ethical decision making difficult sometimes, because what you're seeing in the session, you already have some cognitive biases, you have some emotions that are going on. So it might be difficult to discern exactly what's happening in the psychotherapy session. So besides being a complex process, I have some general thoughts and guidelines. So as I said before, I want to move away from the dichotomous thinking of ethical versus unethical. I don't really think that it's helpful to think about ethical decision making in terms of that. It's not a very nuanced approach. As I said before, in a group setting, it shuts down the conversation. In your own mind, my hope is that you'll be able to conceptualize ethical decisions in a different way in order to broaden your understanding of ethical decision making. Another very important guideline is with many ethical decisions, there may be no one right or correct answer for everyone. And I think this is very important because when I post ethical vignettes on ethics and psychology, I frequently get emails from people who say, we've worked through the ethical analysis, we've come up with different ideas about what we should do or what each person needs to do. What's the real answer? And many times, because there are so many variables and each person brings with them their own biases, their own values, their own views on psychotherapy, that two people may come up with very different answers to the same ethical dilemma that may be correct to each. Now, I'm not saying that anything goes, and as long as you can come up with some rationale, you're able to justify any ethical decision or any action in psychotherapy. But I think the reality is sometimes people will derive different right answers or a different way of thinking about it. Sometimes that you need to pick which you think is the best of several good explanations or several different alternatives. So again, we want to move away from that ethical versus unethical, the right answer versus the not right answer. Again, it needs to be a more nuanced approach. And the third important general thought is that most clinicians, most psychologists make ethical decisions on a daily basis. So these decisions are not gut-wrenching or heart-pounding decisions, but life in daily psychological practice are filled with examples of ethical decisions. And again, to give you one really brief example, is you have a new patient, they've read your informed consent sheet. Do you take time to go over the informed consent sheet, or do you just make sure that they have it signed? So again, some people feel like it's just a necessary evil and have them sign it. Other people use the informed consent process as a means to really convey what's going to happen in psychotherapy. So again, that's what I mean by ethical decisions are made by psychologists on a daily basis. It might be just the way that you practice. So speaking of ethical decisions, let's just explore two very simple or rudimentary models of ethical decision making. So the first one is a very overly simplistic model. And what's involved is you have a rational psychologist who is given a code of ethics and a state law, and they learn the rules, and because they're a rational psychologist, they apply the rules, and then outcomes will follow. So again, hopefully most people do not think of ethical decision making in this way, because it is much more complicated than that. I used to do a presentation on ethics called Know the Code, and I think people do need to know the code, but knowing the code is one of the steps to making a good ethical decision. It's not where it starts and stops. So ethics is more than a code. Now we will move to the second model, and again, I've seen the first model proposed by some presenters, and I've seen the relational model proposed. That's the second model to just start thinking about ethical decisions. Is broken down into know the code, which is the first model, plus know your patient. So you have in the room, you have a psychologist and a patient, and we'll just say it's not group therapy or couples therapy or family therapy, it's just individual psychotherapy. So you have the psychologist who learns the rules, can apply the rules, and believes that the outcomes will follow, but that's based in part about knowing your patient and understanding patient dynamics and understanding the therapeutic relationship. Again, it's an overly simplistic model, and there are many more factors involved in ethical decision making than just you, the psychologist, the rules, and the patient. So with those simplistic models in mind, I want to flesh out 4 types of decision making that happens in clinical practice that is often referred to as ethical decision making. In essence, there are 4 broad types of decision making, and as I've consulted with others about ethical dilemmas or ethical decisions, I try to figure out which type of issue is really at the heart of the matter. And the 4 types of decision making in a psychologist's practice are: number 1, clinical decision making; number 2, risk management; number 3, legal decision making; and 4, which is what you're here for, ethical decision making. And ethical decision making is broken down into 2 parts, which includes both professional ethics as well as personal ethics, personal values, or the psychologist's morality. While these different domains or types of decisions overlap, there are certain characteristics about each that make it different than the others. Therefore, it's important to understand the basis of the issue. What's the basis of the dilemma? What is the psychologist confused about or concerned about prior to even moving forward with ethical decision making? So let's start then with clinical decision making. Some clinical consultations can be, what is the best clinical intervention for this patient in this situation? Artfully vague, I know. It is typical for patients to come in with one presenting issue, then switch to a different issue. Given the psychologist's skill level and expertise, the shift in the patient's needs sometimes creates uncomfortable feelings for the psychologist. So someone may see this as an ethical dilemma when it's really a clinical dilemma. Another example of a clinical consultation is, what are the best psychological instruments to answer the referral question? While a simple example is to diagnose a patient with an intellectual disability, the astute psychologist will administer both an IQ test along with at least one adaptive scale. So that way you can meet the definition of what it is, what it means to have an intellectual disability, which is both IQ scores that are -2 standard deviations below the average, as well as comparable functional abilities. A more tricky clinical issue may include how to evaluate the risk of a patient. So some people may be referred to psychologists because they pose a homicide risk. So that might be a question, is what are the instruments that I need to make sure I'm doing an accurate evaluation, an accurate risk assessment? Again, I can appreciate the ethics of it, but that's more of a clinical question. Yet another example is patient conceptualization. How do you conceptualize the patient? Some people might want to use the word diagnosis. I'm okay with that. So are you dealing with someone more with the constellation of a bipolar disorder, or is it a like major depressive disorder with an underlying personality disorder? So again, trying to get the most accurate diagnosis or the best conceptualization, clinical conceptualization, does have an ethical overture or overtone. However, this is primarily a clinical question. My last clinical example is, my patient continues to struggle after 8 sessions. What should I do? In all of these examples, the primary focus is on a clinical issue. So what am I not doing right with this patient? Am I not working correctly? Is it not adequately? Did I not adequately diagnose the person? But those are, again, more clinical types of issues, more clinical types of questions. So what we're going to do now is move down to the risk management slide. And in risk management, the psychologist is focused on how risk can be minimized, or how can the psychologist minimize or lessen his or her liability. From a risk management perspective, some psychologists avoid certain types of work that have higher liability risks, such as custody evaluations or working with clinically complex patients, or, as I just mentioned previously, doing risk assessments. So when you make those choices, you are either elevating or decreasing your risk. So other risk management issues can be, do I have the essential paperwork signed by my patient? So for example, did my patient sign the informed consent? Does my patient understand my informed consent? Does my informed consent sheet reflect my practice? Are my practice policies up to date? What are the key pieces of information to have on my voicemail message? So when patients call in, if they're in crisis, what should my voice message say? Most all of these have a risk management component to it, and that's what people seem to be asking. So it's more about, how do I minimize my liability, more so than best practices. And I just would like to make a quick note here on false risk management strategies. Oops, went too far. Within the domain of risk management, there are a number of urban psychological legends that still exist in today's internet world. So I just want to say just a few quick words about this. Inaccurate ethical memes, M-E-M-E-S, memes abound, such as always have a suicidal patient sign a no suicide contract. Well, I can explain this in a much more detailed way, and if you go to Ethics and Psychology and type in suicide contract, hopefully my article will pop up. But the idea is that there is no evidence, I'm going to repeat this, there is no evidence that a no suicide contract is an empirically validated instrument. So what this means is that there's no evidence that no suicide contracts actually prevent patients from attempting suicide. This is not the standard of care, a no suicide contract. Again, hopefully people already know this, and I'm just refreshing their memory. Another false risk management strategy is never touch a patient. Always remain at a professional distance and never engage in dual relationships with patients. Okay, these are all false risk management strategies because, just to give a brief example again, is I work in central Pennsylvania and I run into patients all the time. It's hard not to have multiple relationships with patients. It's the difference between what is a boundary crossing versus a boundary violation, and I promise in the future, away from the vignettes, I'm going to dedicate an entire podcast to false risk management strategies because ironically, what happens with false risk management strategies is they actually help you provide worse care than you would if you wouldn't do them. So it's ironic, and I think it would be important for folks to learn more about that. Okay, so the third domain in this larger view of what are ethical decisions or what people think are ethical decisions are legal decision making issues. So some examples of this might be, am I compliant with state laws and regulations? And usually people will start off with, what does the law say about? And then they ask the question, what does the law say about regulations, or what are the state laws that someone can interpret for me? So most of the time, if you want to know what the law says, you can rely on ethicists, but it's probably better to ask a lawyer. So is my practice HIPAA compliant? Sure, you can get another psychologist to review, another knowledgeable psychologist to review it. It might also be helpful to have a lawyer look at your practice and to make sure that you're HIPAA compliant. Questions may arise about case law in a state that you may not understand. It's probably best to consult a lawyer. So I really encourage folks, if they want a legal opinion, they need to seek out a lawyer, not an ethicist. So legal decision making and legal questions have their place. The issue is when to call one in. And finally, we get to ethical decision making. As with the simpler models outlined earlier, ethical decision-making in psychology relies upon the American Psychological Association's Ethical Code of Psychologists and the Code of Conduct. As stated earlier, the psychologist needs to know the ethics code as a first step. Without knowing or consulting the ethics code, it's very difficult to begin the ethical decision-making process. I will make sure that there is a link to APA's ethics code. You can find it on their website as well. Ethical decision making focuses on professional ethics. The types of ethical decision making varies widely. However, these questions or dilemmas can be traced back to the APA ethics code to find out usually what is the best thing to do. Many times the question of, quote, am I being ethical, unquote, translates into, quote, am I practicing consistently with APA's ethical code and code of conduct? Now, besides the code of conduct, APA has 16, count them, 16 guidelines. You can find all 16 guidelines on Ethics and Psychology or through the American Psychological Association. Maybe I'll post a link to that as well. When I first started the Ethics and Psychology site several years ago, I was amazed that there were 16 guidelines. I did not know. Perhaps you are now amazed as well. So here are the guidelines. They are on telepsychology, forensic psychology, working as a parent coordinator, record keeping, child custody evaluation in family law, working with girls and women, practicing with older adults, multicultural education, training, research, practice, and organizational change, practicing with psychopharmacological issues, child protective matters, practicing in the healthcare delivery system, screening and diagnosis of autism, test user qualifications, working with lesbian, gay, and bisexual clients, and evaluation of dementia and age-related cognitive change. Now, you may all say, well, wait a minute, John, that was just 15. I counted them. Well, I count 16 is the guidelines on making guidelines through the American Psychological Association. So that's where you get the 16th guideline. Psychologists need to know about these guidelines as well in order to determine if they are practicing within the parameters set forth by the American Psychological Association. However, ethical decision-making does not occur in a vacuum. The psychologist has some intention or some motivation for trying to assess ethical compliance or to work through ethical dilemmas. Ethical questions and dilemmas range from, number one, whether the person is asking about meeting the minimum standard, and or, number two, what is the absolute best way to handle a situation. A helpful metaphor is trying to determine if the psychologist is contemplating meeting the standard of care or asking about the ethical floor versus a question about what is the absolute best way to deal with this situation, in which the psychologist is asking about reaching for the ethical ceiling. How consistent is my practice with the APA code, or how can I go above and beyond the minimum standards, are the ranges that most people ask about. There are times when psychologists contemplate about going above and beyond the ethics code, or how can I aspire to do what is right and best in this situation? This is a supererogatory perspective. I don't get to say supererogatory many times, but it roughly translates into going above and beyond the call of duty. Given the American Psychological Association's ethical code of psychologists and the code of conduct, as well as the 16 guidelines, ethical decision-making does not occur in a vacuum. Ethical decision-making is more than a code. So part of what I want to bring to your attention is that a psychologist also has their value system to consider when contemplating ethical issues. And what we will see is, after reviewing the personal values, ethics, and morals of an individual, we'll see what model is available to help us combine professional ethics and personal ethics. Now, I just want to take a few moments to talk a little bit about personal values, ethics, and morality. Some folks are concerned about their own personal ethics or morality when they get into a bind. And the issue is not to be confused with risk management, but the issue is, what are my values and how much do these align with the APA code or perhaps your state law. So sometimes psychologists feel so strongly about something that they want to buck the system, so to speak, or to have their own personal values trump professional ethics. And usually this is when folks have too much compassion or wanting to do too much for patients, which again we're going to address soon. Simultaneously, psychologists need to be aware of their own personal values. I want to emphasize that. Psychologists need to be aware of their own personal values. And psychologists need to be aware of their own emotional responses to patients. Sam Knapp and I recently wrote an article about countertransference based on moral emotions. But your personal values, your emotional reactions are a good source of information about ethical decision making. And again, we're going to get into this probably in the next in part 2 of the podcast. So again, just to sum it up, it is important for psychologists to be aware of their emotional reactions, their values, and their own ethics when it comes to ethical decision making. Now, I have found a model, or people have given me the model. I'm not sure how you want to phrase that, but the best, stress that, the best model for pulling together professional values and personal ethics is the Handelsman, Gottlieb, and Knapp article on the Acculturation Model. And I will have a link to that on Ethics and Psychology on the podcast there. They take Berry's model of acculturation and apply it to ethical development. Their model looks at how well a psychologist integrates his or her values and behaviors into the ethical culture of psychology. Psychology has a normative set of principles, behaviors, and conduct found both in the APA code as well as in state licensing law, or at least some state licensing laws. So the acculturation model is a good way of thinking about how you can remain a lifelong learner. Plus, it provides another way to discuss ethical behaviors and decisions without using the word unethical. So what exactly is acculturation? Acculturation is a process to change the cultural behavior of an individual through contact with another culture. And this process of acculturation occurs when there is an adaptation into an organization or a society. So think back to when you were, or think back to, not necessarily think back if you're a grad student, think about this now, about how you're being introduced into the culture of psychology, whether it's through coursework, whether it's through supervised experience. There are certain norms or ways of behaving that you're being taught that this is how we do it in psychology. So the acculturation model provides an integration of your personal ethics that you grew up with, that you believe. So again, most people, when you grow up in a family, you have some kind of family values, perhaps religion, that teach you about the difference between right and wrong. So you have your own personal values that you've developed, and then you're trying to understand that psychology has a system of shared and distinctive norms, beliefs, and traditions. And again, the set of beliefs is reflected in our ethics code, but then it's a melding, or it's a weaving together of personal ethics with professional ethics. So one example is the therapeutic relationship. The therapeutic relationship is a fundamentally different relationship than any other relationship. And again, that's for a variety of reasons, including, just quickly that, there's a fiduciary responsibility, that the psychologist is learned and has a body of knowledge and has a certain degree of power over the individual who comes in and literally knows nothing or very little about the psychotherapy process. So there's just a power imbalance and a fiduciary responsibility that the psychologist has to the patient. So the ethical acculturation model helps educate psychologists to be, or psychologists in training, that the therapeutic relationship is not a friendship. So for one, again, quick example is, it's usually not a good idea to loan patients large sums of money, because again, you might do that with a friendship or in a family relationship, But in psychotherapy, there's usually no real good reason to loan patients money or to accept loans from patients. So, again, that's just to highlight the difference between what a friendship or family relationship is in psychotherapy. So as people are moving into their role as a psychologist, they have to understand the parameters and the boundaries of what it means to be an ethical psychologist. So acculturation is a process, and the acculturation of an individual can be a complex process. Some parts of a psychologist's practice and lifestyle may be easily acculturated, while others may not. And the process will likely continue throughout the education or career of a psychologist because, again, the rules change. For example, in the last 10 or so years, this whole idea of social media has exploded. So the question is then, even if you've been a psychologist for 20 years, the rules have changed now in terms of how you can communicate with patients on the internet via social media. So again, what are the best ways of utilizing social media to be an ethical psychologist? Okay, so hopefully that's clear. And the ethical acculturation model goes from higher or lower identification with a person's personal value system, or a psychologist, we'll just keep using psychologist personal value system, versus higher or lower identification with the value system of psychology. So what this does is it gives us a 2x2 matrix. Now this is why I put the slides together so you can see the matrix. So across the top of my matrix, the way I have it drawn, is higher on professional ethics versus lower on professional ethics. That's at the top of the 2x2 matrix. And then on the side is higher on personal ethics and then lower on personal ethics. That means the emphasis. So it's a higher emphasis on professional ethics or a lower emphasis on professional ethics. So from this 2x2, we have 4 categories in which an individual can be described using this acculturation model. So an individual can exhibit marginalized behaviors, separated behaviors, assimilated behaviors, or integrated behaviors. And each of those is a category that we're going to go over right now. So the first one, and I picked this is because it's probably the easiest to describe and to think about, is the marginalized category. So on the matrix, the person is lower on professional ethics and lower on personal ethics. And this is typically what you think about, or what people think about, when they talk about quote unquote unethical behavior. The psychologists exhibiting marginalized behaviors or marginalized judgments present the greatest risk of harm to patients because, number one, they lack the appreciation for professional ethics. And then number two, they're motivated more by self-interest. So again, lower on personal ethics, lower on professional ethics, so that they end up having less concern for patients. And again, these are individuals who have the greatest risk of harm. Now, giving some nuance, the assimilated strategy. The assimilated strategy is when an individual is making decisions or behaving with a higher emphasis on professional ethics and a lower emphasis on personal ethics. And again, this is one of the reasons why it's important for people to understand what their own personal ethics are, because this is going to be part of the equation when you're trying to make an ethical decision with a dilemma. So used in kind of a little bit more extreme stance, the assimilated model is more toward risk management, and individuals in an assimilated style usually develop an overly legalistic stance to the dilemma. So in its extreme, an assimilated psychologist would rigidly conform to certain rules while missing, the broader issues. And when we get into actually ethical decision making, we'll give some really good examples of what an assimilated psychologist might look like. The next slide is the separated stage and or separated style, and this psychologist is lower on professional ethics, a lower emphasis on professional ethics, and a higher emphasis on personal ethics. And this is what I was talking about earlier when people do their own gut check and say, well, my personal ethics say that I really need to do X when the ethics code says I really need to do Y. So in those situations, compassion can override good professional judgment. And in the extreme, and again, I'm trying to give you just kind of the extreme example, is failure to recognize the unique role of a psychologist. So like I said, a real simple example is you're trying to be compassionate. Somebody is really down on their luck and they only need a couple $100s to make their mortgage payment or their rent. And the psychologist really needs to realize, although they have that money, to loan them several $100s is probably not a very good idea. And of course, the final style is an integrated style, which of course everybody listening to this podcast is an integrated psychologist, of course. I'm saying that with a smile on my face. The integrated style is high emphasis on both professional ethics and a high emphasis on personal ethics. So what the psychologist attempts to do is implement their own personal values in context of their professional role. So integrated psychologists are really reaching for the ethical ceiling, really trying to integrate their own personal values with professional values to come up with what is the best answer to any type of dilemma or issue in practice. And many times that psychologists are trying to move toward aspirational ethics, or really trying to do or to give the highest quality of care. So that's in a nutshell what the acculturation model is. And again, the reason I'm emphasizing this is because it's a nice model when you have to look at your own personal ethics and professional ethics and then see how these meld together and how you make decisions. A little self-disclosure here. And when I do self-reflection on some of the dilemmas I'm working on, I move primarily into an assimilated strategy. So the emphasis is first on what are the rules. So that's what I think about. Okay, so let me think about what are the rules here. So I try to remember what the rules are, and then pull in my own personal values and personal ethics. So you might want to look at your own and reflect on your own decision-making style, which again will come in more into focus in part 2. So now that we've talked a little bit about what ethical decision-making is, and comparing and contrasting that to clinical decisions, legal decisions, and risk management issues, we're going to spend some time now looking at the principles that are underlying the ethics code. And so I will have links to both the Kitchener article and to Beauchamp and Childress's book on ethics, because both of these authors use principle-based ethics to describe how to go about making good ethical decisions. Coming into the home stretch, we're going to be talking about autonomy, beneficence, nonmaleficence, fidelity, and justice. So these are the 5 principles on which the APA Ethics Code is based. So we're going to talk first about respect for autonomy. Respect for autonomy does not mean promoting autonomy, which means individuation or separation. It is the means of respecting the autonomous decision-making ability of the patient. So what we do is we respect that the patient has the ability to do what they want to do. Autonomy encompasses freedom of thought and action. Individuals are at liberty to behave as they choose. So in psychotherapy, autonomy is played out when patients help determine the goals of therapy. Autonomy also plays out when making life decisions, such as getting married or getting divorced. Autonomy also means respecting their desires in terms of scheduling appointments and terminating treatment. So one of the things that I typically say is how soon, at the end of a psychotherapy session, how soon do you want to come back? Some people say, yep, see you next week. Other people say, well, maybe we should make it 2 weeks, and which is fine. And I respect their autonomy in making that decision. So autonomy and consent can be found in Standard 3.10 when psychologists conduct research or provide assessment, therapy, counseling, or consulting services in person or via electronic transmission or other forms of communication. They obtain the informed consent of the individual or individuals using language that is reasonably understandable to that person. So that's autonomy. We're going to now hop to beneficence. And again, hopefully this is a review for most people. Beneficence is the principle of benefiting others and accepting the responsibility to do good that underlies the profession. So beneficence is providing the best treatment possible, that the psychologist is going to exhibit competency in whatever they're doing. So whether you're treating a panic disorder or someone with bipolar disorder or someone with who falls on the autistic spectrum disorder, that you have the competency to provide good treatment that people will likely benefit from. And another example of beneficence is referring patients to others when needed. So all of those fall under the category of beneficence. And I believe that psychotherapy in and of itself needs to be beneficent. And again, that's what this principle stands for. Beneficence can be found in Standard 2.01. Psychologists provide services, teach, and conduct research with populations and in areas only within the boundaries of their competence. The third foundational principle is nonmaleficence. Nonmaleficence, summing up, is the principle of doing no harm. Above all, do no harm. That's nonmaleficence. So nonmaleficence can be thought about, again, in demonstrating competence in that you don't damage other people, maintaining appropriate boundaries. And as I said before, there are many times when boundary crossings occur, but boundary violations are more of the problem, which again, we'll do another podcast on that. Another example is not using an experimental technique as the first line of treatment. So, rather than, immediately engaging in some type of therapeutic intervention you learned the week before, that you really assess what's going on and only use those techniques that you really feel are within your bounds of competence. And again, under the principle of non-maleficence, providing benefits, risks, and costs, this is again the idea of informed consent. So, non-maleficence, psychologists take reasonable steps to avoid harming their clients, patients, students, supervisees, research participants, organizational clients, and others with whom they work, and to minimize harm when it is foreseeable and unavoidable. And that's in Standard 3.04. The fourth principle is fidelity, and this principle refers to being faithful to commitments. Fidelity includes promise keeping, trustworthiness, and loyalty. So psychologists should really avoid conflicts of interest that could compromise therapy. And again, a conflict of interest could in fact be a boundary violation. As I had used this example before, keeping information confidential. That's your promise to your patients, that you're not out gossiping about them or just saying things to other psychologists just for the thrill of it. It's really, you need to keep the information as confidential as possible. and to adhere to the therapeutic contract, which again hopefully is outlined in your informed consent, that you will adhere to session lengths, phone contacts, what happens between psychotherapy sessions. So whatever you agree upon with the patient ahead of time in terms of your therapeutic contract or informed consent, that's what your fidelity is. And fidelity can be found in Standard 4.01. Psychologists have a primary obligation and take reasonable precautions to protect confidential information. And the last foundational principle is justice. Justice primarily refers to treating people fairly and equally. And one good example is that no matter what insurance the person has, whether it's really good insurance and they pay you a higher rate than a lower insurance, that you treat these people fairly and equally. So this is found in 3.01. In their work-related activities, psychologists do not engage in unfair discrimination based on age, gender identity, race, ethnicity, culture, national origin, religion, sexual orientation, disability, socioeconomic status, or any basis prescribed by law. So there they are, the 5 foundational principles. So we've done a lot, probably getting close to 45 minutes or so of review, and we still haven't talked that much about ethical decision making. So this is where I kind of want things to wind up, and we'll go into part 2 then. But the APA code has no ethical decision-making strategy. There's no algorithm or formula. So this means that to comply with a standard may not always be readily apparent, because there's no, like I said, no algorithm, no way to figure this out, or that the code really does try to help you figure it out. So 2 seemingly competing standards, which we're talking about, whether the person's autonomy versus beneficence, appear equally appropriate in a clinical dilemma. So application with a single standard or a set of standards appears consistent with one or more aspirational principles, but not another. And I know again that I'm speaking in a very vague manner, but I'll just try to give you one brief example. So let's say you have a severely depressed individual who shows, cognitive vegetative symptoms of major depression and has been suicidal, and they are refusing psychotropic medication. So they're coming to see you twice a week because of the severity of their depression. You've offered them inpatient treatment. They've said no, they don't want to go inpatient. They've said they don't want to go to a intensive outpatient program. They don't want to go to a partial hospital program. And then they also don't want to take psychotropic medications. So while you're seeing them twice per week, you're respecting their autonomy, but in terms of beneficence and also doing no harm, maybe they really should be strongly encouraged to seek a higher level of treatment or start taking psychotropic medication. So again, when you have a patient who's saying, I don't want to do these other things, I want to try to go, my decision is I just want to go twice a week outpatient therapy, you're respecting their autonomy, but is beneficence being upheld by allowing them to suffer as they are with symptoms of rather severe depression? Okay, so let's get to the summary of today's presentation, podcast, lesson, lecture, monologue, whatever you want to call it. We reviewed that ethical decision-making can be complex. We distinguished ethical decision-making from clinical decisions, risk management, and legal questions. While there is some overlap, ethical decisions really need to do with professional ethics and personal ethics. Again, that's the general idea. There are some exceptions. We reviewed the Acculturation Model, both as a way to acculturate to psychology as well as how ethical decisions are made. And we reviewed the 5 foundational principles on which the APA Code is founded. We've touched on the idea that the APA Ethics Code does not have an ethical decision-making strategy, and that ethical dilemmas are usually a function of two competing foundational principles. So hopefully you enjoyed this. Hopefully this makes sense. I can give some guarantee that it will make sense once we start dissecting or start analyzing vignettes, which will be in a couple more podcasts. But thank you for listening. Look forward to part 2. Follow me on Twitter. I'm at John Gavazzi. Any questions you can send to me, johngavazzi@aol.com. And until next time, do the right thing.